Hello everyone. So today we will study how to manage a case of fibroid. Most of the patients of fibroid are asymptomatic, but many of them will present with heavy menstrual bleeding. If the complaint is there, and the most common complaint is heavy menstrual bleeding. When a lady comes with heavy menstrual bleeding, the first thing which you ask is whether you have completed your family. If she has completed her family, the management could differ. If she has not completed her family, then you will map the fibroid. Which type of fibroid it is? If it is a case of submucous fibroid, that is within the uterine cavity, then you will assess whether it is type 0, type 1 or type 2. Type 0 and type 1, you can remove it through hysteroscope, that is hysteroscopic myomectomy. Whereas type 2 fibroid and the fibroid of size more than 5 cm, you can't go ahead with hysteroscope, so you will do laparoscopic myomectomy. Right. So this is about submucous fibroid. But if the patient is having intramural and subserosal fibroid, you will go ahead with medical management. And the medical management, we will use the drugs. There are two types of drugs. One is reduce the bleeding but will not affect the size. Another is it will reduce the bleeding as well as reduces the size. The first thing which will reduce the bleeding but not affect the size is the one which will support the endometrium. So like OC pills or IUCD Mirena, that is progesterones, and tranexamic acid. These are the things which will support the endometrium. It will not allow the endometrium to shut off every time. So that is going to reduce the bleeding. Whereas coming to this other group of drug which will reduce the size as well as bleeding, those are GnRH agonist and antagonist, right? So we prefer antagonist more than agonist. Why? GnRH agonist, these are not orally active. These are injectable preparation. And the second thing is they initially cause flare up and then there will be reducing of the symptoms, because when you give GnRH agonist continuously, initially there will be a flare-up reaction, the symptoms will aggravate. Afterwards only the symptoms will reduce and the patient will get menopausal-like symptoms because of reduced estrogen. So GnRH antagonist on the other hand, they are orally active. So they are not injectable preparation and there is no flare-up reaction, but from the initial time only patient will get reduced estrogen and menopausal-like symptoms. So we are going to give add-back therapy like norethindrone or ethinyl estradiol. These are the add-back therapy when the patient is having GnRH antagonist. These are the two types of medical management. That is, one is to reduce the size as well as bleeding. Another is only to reduce the bleeding, no need to reduce the size. Though you give medical management, it acts only till a short time. So whenever you are giving the drugs, that time the patient will be relieved of symptoms, and again when you stop the drugs, patient will get heavy menstrual bleeding. So what next? The next is we can't do anything. So we have to go ahead with the furthermore surgical procedures which will affect her fertility. So in the patients who has completed her family, we can go ahead with uterine artery embolization or magnetic resonance guided high focused ultrasound, and the last step is hysterectomy. And in the hysterectomy, we have two types. One is abdominal or vaginal. If you are doing abdominal, it can be open surgery, that is total abdominal hysterectomy, or a laparoscopic assisted laparoscopic assisted hysterectomy. And if you are doing vaginal, that is called non-descent vaginal hysterectomy, because there is no descent of the fibroid, but still you are doing through the vagina the hysterectomy, that is called non-descent vaginal hysterectomy. This is in brief about the management of fibroid. Thank you.